Thank you very much. Oh, okay. Now I'm fully powered here. So it seems very loud to me, but if it's not too loud for you, then that's okay, I guess. So yeah, thank you very much for doing something like this. When I drove over from Madison this morning, I thought, what is the difference today between seeing patients in the clinic? The big difference is that we have time to talk about things we cannot talk in clinic about. And this is not really just sort of, okay, what is step A, B, C from now going forward? But what I really want to do this morning is to sort of explain a little bit, like the other speakers, and really enable you to understand what is sort of driving our decision process, what are really the new recent developments for systemic treatment. And a lot of these treatments really came out of research, out of the lab. And we've seen by Dr. Glinnert, he presented it already, the first patient described with mycosis fungoides. If you're wondering, this is on purpose, right? This thing didn't break down. Because this is what I would have shown you in 1806, 1805 about what I'm going to show you now. Treatment of advanced stage disease. What do we know about the disease? We didn't know anything. We would have known nothing about it. And I would have basically ended here. But since then, we have learned so much about how to diagnose the disease. We have learned a lot about its biology, even though it's way not enough. And a lot of what we have learned really also triggered our therapeutic and management decision trees and algorithms. And Dr. Glinnert referred to this already for the NCCN guidelines. The NCCN brought that out for every single type of cancer out there. And one of these cancers treatment and diagnostic and treatment guidelines is mycosis fungoides and Sézary syndrome. We'll go about, I'm not going to go into the sort of depth of this table here, but this table gives you an idea of sort of what the options are and how many options we actually do have alone as a single agent or combined in multiple different ways. And I will talk about a few of those treatments. So, as you've seen before, probably from Dr. Wood and from Dr. Cheney's lecture, there are different stages of the disease. And now, I'm just wondering, okay, here's a laser pointer. So we are mostly talking about now advanced stage disease in my presentation, the widespread plaque disease, and then tumor stage disease. And I don't think we have to go over this, but this basically shows you this has been covered, the early stage disease, which you treat mostly with really skin-directed treatment. And skin-directed means you put it on the skin or you shine it on the skin directly. And then for the advanced stage disease, most of the time really systemic treatments are needed, but most of the time together maybe with these early stage treatments. We usually never stop those necessarily. And I also want to take you a little bit back. I'm not sure whether Dr. Wood has shown that, but I want to take you a little bit back into the was too fast, the basic science side, because this is the basis to understand one of the very recently FDA-approved treatments for mycosis fungoides. And without going into the specifics here, but what we now understand is that, and maybe in 10 years that's different again, but at this point we have good data to suggest that mycosis fungoides on the one side and Sézary syndrome on the other side are different diseases, distinct diseases, because they arise in distinct T-cell populations. And it makes immediate intuitive sense that you have the so-called skin-resident T cells after those were discovered in Boston by Rachel Clark, Tom Cupper's group, after people discovered the skin-resident T cells, which are really mostly living in the skin and sometimes survive for many, many years. These are the cells that give rise to mycosis fungoides. there is really no, in most cases, significant blood involvement, significant lymph node involvement, because these cells don't travel, they stay in the skin. What is keeping them there are lots of adhesion molecules, and the one I would like to point out is this so-called CCR4, or chemokine receptor 4, because that will become relevant again later in my talk. So, and then that really contrasts with Sézary syndrome, where the malignant cells, the lymphoma cells, travel back and forth between skin, lymph node, blood, and they are mobile. And we call those the circulating or central memory T cell. And yes, they do have the CCR4 as well, but they have lots of other adhesion molecules that tell them or make them go, leave the skin and go back and forth. So, and the other thing I would like to talk a little bit more about, at least briefly mention that those conditions exist, as some of you may very well know, the CD30 lymphoproliferative disorders. Why would I like to talk about them really quick? Not only because there's the second most common group of cutaneous lymphomas, cutaneous T-cell lymphomas after mycosis fungoides and Sézary syndrome. They really represent a big chunk of the disease, but also because we have another one of these more recently approved treatments actually is able to target those specifically. And we basically break this spectrum of disease down into the lymphomatoid papulosis on the one end of the spectrum and the primary cutaneous anaplastic large cell lymphoma on the other end of the spectrum. And some cases are really hard to classify, and they're called the borderline diseases, where things is a little bit more in the gray zone. So this is how the lymphomatoid papulosis can look like. I don't want to spend too much time here, but it is actually interesting to note that a lot of these lesions, once they show up, they tend to stay around for a few months and then they go away. So this is not one of the conditions where we need really the big bullets to treat, but there are some cases that are more stubborn and more treatment resistant, and we actually do need systemic treatment for cases of lymphomatoid papulosis. And if you happen to read sometimes the pathology reports, if there's anybody in the room here with this condition, LYP, the pathologists at this point really subclassify and subgroup, and this is just really a small representation there. If we really want to take it to the extreme, we could come up with more subclassifications of lymphomatoid papulosis. It is important to note clinically, they really tend to behave the same. Also, the treatment really tends to be the same. And there are more modern approaches or very recent approaches ongoing to sort of maybe, you know what, maybe we should kind of involute, make all these different subgroups sort of, smaller in number again. The other thing I want to talk about is the cutaneous anaplastic large cell lymphoma. And you can see here, sometimes it may look very much like the picture I showed you before, the lymphomatoid papulosis. And maybe in these cases, we can call it borderline, but usually anaplastic large cell lymphoma are these solitary or grouped, large, rapidly growing tumors on the skin. And what makes these anaplastic large cell lymphoma and the lymphomatoid papulosis unique is in its name. They are in the category of CD30 positive lymphoproliferative disorders. And the key here is the CD30. So this is how the anaplastic large cell lymphoma looks like under the microscope. And you can see the skin is basically packed with these large, very angry looking cancer cells, the lymphocytes. But what is special here, that the vast majority of these cancer cells really express that surface protein called CD30. We also find CD30 on most cases of lymphomatoid papulosis. So that is sort of the common denominator. And this is important because nowadays we can actually target CD30. So And the last thing before I go into the treatment, I also want to talk about, even I have to admit, these pictures look absolutely horrible. They are from several years ago, and I think in a lot of patients we are able to hopefully in cases prevent progression like this. But this is the scenario here of the large cell transformation when the sort of indolent or less aggressive form of the disease, all of a sudden there's a molecular switch which we don't completely understand, but all of a sudden the disease becomes very aggressive, lots of tumors form. And it's interesting to note that even in these cases, what we find in some cases, there's all of a sudden upregulation or expression of this protein called CD30, which we can target nowadays. And it seems to be that the patients who do have CD30 expression in the large cell transformation seem to be doing a little bit better than cases where that CD30 expression is missing. So if this was shown before and you are totally aware of it, then I apologize, but this is relevant to some of the modern treatments. So, and you know, I showed this several years ago in 2014 here, and this is from a publication from 2012. And you notice one thing: whenever we look at these treatment algorithms, whether with colors or like in the NCCN table without colors, it always looks extremely confusing. And we always know in medicine, if a treatment algorithm looks like this, we just don't have magic bullet. And that basically means that for every single stage, there are multiple options out there. There's a good thing about having multiple options, because if A, B, C fail, that means most likely we have D, E, F. But it also means, and that is definitely true for cutaneous T-cell lymphoma, who tells us where to start? Do we really have to start with A, followed by B and C, or should we start with D, then A, and then B? We just don't know enough about sort of how to sequence treatments, or sometimes even how to combine best the treatments. So here, coming back to this table form, I'll start now going over some of the more recently FDA-approved treatments for cutaneous lymphoma, which basically came directly out of the basic science lab, and then some of the older, well-established treatments that are very, very frequently used for mycosis fungoides, Sézary syndrome, LYP, but also for the anaplastic large cell lymphoma. But before I go there, I want to really point this out, and this is really what I think has dramatically shifted the way we treat cutaneous lymphoma, and you can even see it if you compare an NCCN guideline table today with 5 years ago, 10 years ago. It looked very different, because at that point, chemotherapy played a large role. Standard chemotherapy, whether it was a single agent or a combined regimen, was much more often utilized than today. And this study here summarized, basically put into numbers, what a lot of physicians who see patients with cutaneous lymphoma always knew and always suspected, but there was no evidence. What this study really showed, and this is now 4 years old, but this study showed really clearly for the first time that yes, chemotherapy works quickly and it works relatively well to suppress the disease, but the response is not lasting. And oftentimes, this study didn't show it, but we know it from other studies, oftentimes the disease tends to be more aggressive after treatment with chemotherapy. So we took that into consideration, and the message here is chemotherapy should really be reserved for extreme cases. And what we really try to do before is the immunotherapy, modulating the immune system, either directly targeting the lymphoma cells in smarter ways, or enabling the patient's immune system to fight the cancer. So, and now I'm going to get into the part that I'll first review, older medications for cutaneous lymphoma, which have been around for quite some time and are often used in clinics really worldwide. And that's actually very interesting. It may differ in early stage cutaneous lymphoma, but once you get to the advanced stages, our treatment, whether you would get in Italy, France, Germany, the US, Canada, or Brazil, or Japan, might be very, very similar. So, and one of the very, very commonly used agents is the methotrexate. Some of you may be familiar with this medication. We use it for LYP. It can be used for anaplastic large cell lymphoma, mycosis fungoides. Even in relatively early stages, you wouldn't use that necessarily in very late stage disease, but it is usually administered orally once a week. That is important. It's not a daily pill, it's once a week. And another trend that really showed up a few years ago, the dosing maximum used to be much higher. People went up to maybe 100 milligrams a week and called that low dose. But now with these other treatments coming up, we tend to go lower and lower, and I usually do not exceed 30 milligrams per week of the methotrexate. If that doesn't do enough, then we either add something else on or we switch to a completely different drug. But if it works, it can actually work for quite some time. Unlike the chemotherapy, some responses are very, very durable. On methotrexate, we have to worry long-term about the risk of damaging the liver, but also, and that may be relatively early, it can really affect the bone marrow and some blood counts may go down. But really, in the hands of an experienced physician or a medical provider, this is really considered a safe medication. And I like to point out that this can be used as a single agent, but often it is also used as in combination with other medications. Here, the steroids, photophoresis, light treatment, or even interferon. So the next thing I want to talk about, and Bob spoke about that a little bit, the topical targretin bexarotene, he spoke about the gel, but it also comes in an oral formulation as pills. And that is a little bit more tricky to manage, especially if you were in Europe, because there the dosing is different and tends to be much, much higher. And I think now they have also adjusted their dosing, but we in the US here really, even though I'm from Germany, but I'm saying but here we tend to really dose it a little bit lower. And maybe even at the initial doses, some of the side effects that will kick in ultimately at higher doses may not play a role. And really the side effects that are notable and almost every patient has to deal with are really the elevated triglycerides. The lipids will go up and the thyroid function will go down. It could also be that some of the blood counts here, specifically the platelets, they may come down, they may be affected. If that happens, we can maybe play with a dose, maybe a mild suppression is acceptable. But what we can manage effectively are elevated triglycerides, and we can also manage effectively the depressed thyroid function by supplying thyroid hormone, the levothyroxine or synthroid. But like I said, basically everybody who tolerates the bexarotene, the initial doses, and shows some response will get to the point that we have to manage triglycerides and the thyroid function. And then another agent, and the sequencing was on purpose because methotrexate is easy to use, and I can tell you every dermatologist in this country and even in the world is familiar with it. We use it a lot. Bexarotene is a little bit more special. And then the next one, because it's not a pill, it's even more special, is the interferon. And interferon is one of these agents that really boosts the immune system. It may kill the lymphoma cells, but at the same time, it might boost the host response, enabling the immune system to kill the lymphoma cells. And some of its side effects are immediately clear if you know that interferon is really a messenger in the immune system. Interferon is the way your immune system talks to its different members during a flu infection, for example. And that makes some of the side effects immediately clear. weight loss, but really just flu-like feeling. And one side effect patients struggle a lot with is really mood changes, all the way to really significant depression that can happen with interferon. From a more objective perspective, it is very well tolerated. Usually, yes, it may also affect the bone marrow, it may affect thyroid or liver, but usually we don't see it. Usually at the doses we are using, it is very well tolerated. And important to note, it is an injection, it is a shot, usually administered 3 times a week, Mondays, Wednesdays, Fridays, for example. And then we are here, even though the number looks very high because we're talking million units, but the volume is relatively small. But really effective doses are 3 to 5 million units of the interferon. And again, like before, interferon is one of the things that you rarely see just on its own. It's usually a combination partner. And then towards the end, I really want to go to the most recent treatments. And those are really the monoclonal antibodies. And the principle of those monoclonal antibodies is that they get generated. Antibodies are important in the immune system. They can find the target, and then they really activate the immune system and induce destruction of that target. And we can use that for cancer too, by generating monoclonal antibodies against proteins, against targets that are on the surface of the cancer cell. And then we can do 2 things. We can either deliver a toxin, poison, directly to the cancer cell, selectively to the cancer cell, or we basically activate the immune system around the cancer cells, which usually wouldn't recognize the cancer cell without this monoclonal antibody. And there are 2 agents out there. The older one is the brentuximab vedotin or Adcetris. That is a monoclonal antibody against, and I mentioned it lots of times before, CD30. So CD30 is expressed in some cases of mycosis fungoides, but it should be there in anaplastic large cell lymphoma and in most cases of the lymphomatoid papulosis. So in this monoclonal antibody is coupled with a toxin, which basically induces cell death in the cancer cell. And here, this is how we, with these newer drugs, how we are really able to measure the response. We look at progression-free survival. We basically measure the time from when do we start the treatment until how long does it take for a patient to pass away from the disease or any other cause. So it could even be a motor vehicle accident. But you can see here that the control arm in red, it drops relatively quickly. And you see a big difference here in the bexarotene arm of the trial. So it shows you there is a response. It seems to kick in relatively fast, and it really lasts for some time. So very promising agent. But 2 things. One is the administration. It is an infusion, and patients have to go to the infusion center. It's usually administered in 3-week cycles on the first day of every 3 weeks. And we usually go up to 10, 16 cycles of this medication. But the side effect that I really want to point out here is the peripheral neuropathy. So there can be numbness, tingling, and that in, for example, the lower leg and feet, and that can be significant. It can be so significant, in fact, that especially if treatment doesn't get stopped early enough at the onset of those symptoms, that it can almost be debilitating. So that's something to keep in mind. Now coming back to this here, which you hopefully may remember, the CCR4, right? CCR4 is the adhesion molecule that keeps the mycosis fungoides cells in the skin. Now, how about we target that? That is also possible nowadays with this new drug Mogameliza or Poteligeo. And here, that's a little bit different. It's a monoclonal antibody, but it doesn't deliver a poison to the cancer cell. It's a monoclonal antibody that gets recognized and really activates the surrounding immune system, which then, in a natural way, destroys the cancer cells. It is also an infusion, and you can see here the curves look slightly differently, but again, the control arm was vorinostat. It's a pill, and the treatment arm is the mogamulizumab. And whenever you see a gap here in these progression-free survival curves and the new medication is on top, then you know it's superior. It clearly does something better. I think what is important to note for all these medications, because I'm showing you progression-free survival, another way to measure is how many people actually do respond, and we call that overall response rate. It would be great if that were 100%. It would be great if it were even 70 or 60%. Reality is, for a lot of these drugs, it is maybe 30, 40%. If you talk to dermatologists, we are really not used to these response rates because we treat skin infection, we treat rashes, and we see much higher response rates. If you talk to cancer doctor, oncologists, they are also not, they wouldn't be overwhelmed with a 30% response rate, but for cutaneous lymphoma, this is just the reality. The likelihood that any given individual is going to respond is maybe 30, 40% for most of these agents. But that's where I said it's good to have these many options, because if one fails, we can either add something else on or switch to something else. Yeah, and like I said, it's also an infusion, and we don't have to go over the infusion regimen, but in terms of side effects, there are two things that are important to note. One is the infusion reaction. We see that a little bit more often with the mogamulizumab than the brentuximab, but that can be managed. The worst case is some Tylenol and other medications before and during the infusion, so that's manageable. The one thing that is really worth pointing out is the rash, because this medication can sometimes induce a rash. And then we have to decide, what does this rash mean? Is this rash a reaction against the drug? Or is this rash cutaneous lymphoma, mycosis fungoides, that's flaring and not responding? And in these cases, it is actually very important that the dermatologist gets involved, that we do biopsies and try to differentiate. Is it just a drug rash in response to the medication, because we may be able to treat through that and keep the patient on the drug, versus the lymphoma really acting up and not responding, and then it may be time to switch to another treatment. So that's a unique point here. That can also happen, but less likely on with the brentuximab. So bottom line, whenever there is a new rash after a new treatment was just started, it's really worth thinking about. Is it a drug rash, something like an allergic or irritant reaction, or is it the cancer flaring? And very, very briefly, that I know is available at MCW here, but also at the UW Health and Medicine with us, the Photophoresis. You would not treat patients with LYP or anaplastic large cell lymphoma with that, also not with classical mycosis fungoides. This is really one of the oldest FDA-approved treatments, goes back to 1988, for Sézary syndrome or the widespread, also with blood involvement, erythrodermic mycosis fungoides. And again, without going into the details here, but this is how this photophoresis machine looks like. We establish an IV access, basically with large needles in one arm. The blood runs through that machine, a medication gets added in the machine, then UV light is shined on the blood that activates the medication, and that then hopefully fights the disease. And I can also tell you, a lot of centers don't use photophoresis just by itself as a single treatment. I think photophoresis may be valuable, but probably in conjunction with other treatments such as bexarotene or interferon. And usually there are no really significant side effects. It's mostly well tolerated. The only problem is the logistical component. If that was there for the phototherapy, like Dr. Glynn had said, that's certainly the case here, because usually this is done in 2 consecutive days. You check maybe in at 9 a.m. and then you stay hooked up to that machine for the better part of the day, and the next day the same thing. And that could be twice a month or just once a month. So definitely a logistical component here. And the last thing I want to talk about very briefly is what you have heard before, the stem cell transplant or bone marrow transplantation. But nowadays, the more appropriate term would be a stem cell transplant. And the idea of that is really that you can do two things. You can destroy the bone marrow. You basically wipe out a patient's immune system. Part of that would be the lymphoma. And because you can go so high in your eradicative treatment that the chances are hopefully good that you wipe out the lymphoma completely. And then the immune system, the stem cells, bone marrow stem cells get transfused back either from the patient, that's called autologous, or from a matched donor, that's called the allogeneic. So you have auto stem cell transplantation and allo stem cell transplantation. And what I mentioned before, the period of intense treatment, that's the so-called conditioning treatment or conditioning regimen, the goal of which is to really wipe out the patient's bone marrow. Almost more importantly would be wiping out the lymphoma and then transfusing the donor stem cells. The problem is, as far as I see it, there are two big problems. One, the toxicity of this. This is a very, very aggressive treatment, and there is significant toxicity, and there are significant side effects, and it can be fatal because that conditioning regimen is a very, very harsh treatment. But also you might imagine that wiping out somebody's immune system, then infusing a new one, waiting for that to really take, so-called engraftment, sometimes that doesn't work. And then the organism is extremely vulnerable to all kinds of infection. Sometimes there's this thing called, it's actually very frequently actually graft versus host disease, where the donor, the infused immune system, starts to recognize the patient's body as something to fight against. And sadly, even really in the centers where this is getting done a lot, and we do have a few patients at UW who are actually getting ready for the stem cell transplant now and who had it in the past, but it is always important to be absolutely honest. This is not, neither that is the magical bullet, because in a lot of the patients, the disease does come back, really telling us that we are not good enough at wiping it out. The conditioning regimen is just not effective enough. So there's more research to do and more things to figure out. So, and then this is really the last slide. Clinical trials. I think almost any one of you really has encountered clinical trials, seen clinical trials. I know on the Cutaneous Lymphoma Foundation website, the clinicaltrials.gov. This is something I think a lot of patients with any type of cancer should be familiar. And there are a few very simple pros and cons. I think the big pro is that it may offer access to a new treatment, to maybe a more effective treatment, but the cons are, and this may be because sometimes we just don't know. There's a reason for us doing a clinical trial, because we want to measure its efficacy. We want to figure out how well is it working, or is it working at all. But anywhere, wherever you would get and enroll for a clinical trial, it is all monitored by the IRB, the institutional review boards. There are very good consent forms. So I think nowadays in 2019, we can say that all institutions in the United States where you have access to clinical trials really try to do everything they can to minimize the risks and side effects of those clinical trial drugs. And keep in mind, the bexarotene and the brentuximab and the mogamulizumab I showed you before, those curves came out of clinical trials. So with that, I hope I gave you a relatively comprehensive, or more actually not comprehensive, but more snapshot view of the advanced stage treatments. There are others I didn't touch on a lot, like vorinostat, romidepsin, other systemic agents, but I think those are really at this point the big players and the newer ones. So thank you very much.